Hey guys, welcome to our presentation on cetuximab in colorectal cancer. So, the biology of colorectal cancer is that it generally arises in the mucosal lining of the large intestine, which includes the colon and the rectum, and that colorectal cancer originates from intestinal epithelial cells that line the colon. Most of these tumors arise from mutations in the self-renewing stem cell population. So the tumor type is that approximately 95% of all colorectal cancer is adenocarcinoma, which arise from glandular cells within the colon lining. The conventional colorectal adenocarcinoma is what we will be focusing on today. However, it is important to note there are different subtypes within adenocarcinomas, including mucinous adenocarcinoma and serrated pathway tumors, but neither of these subtypes are targetable by our chosen agent due to RAS mutations and BRAF mutations further down in the pathway. The conventional adenocarcinoma still has an intact adenocarcinoma sequence, which are unlikely to carry the BRAF genes and KRAS mutations, and they typically overexpress EGFR. So the main tumor suppressor gene in colorectal cancer is adenomatous polyposis coli, or APC as we're going to call it, and it regulates the Wnt beta-catenin signaling pathway, which promotes the degradation of beta-catenin via the destruction complex, which is the APC, axin, GSK3, and CKI on the right. And it maintains cell differentiation and controls intestinal stem cell renewal and helps in chromosomal stability and cell migration polarity. So as we can see in the right-hand side, this is when the Wnt signal is off, and the destruction pathway can phosphorylate beta-catenin, which doesn't allow it to go into the nucleus, and it doesn't cause cell differentiation. So when there's a mutation in APC, the destruction complex cannot degrade beta-catenin. So it's kind of like when the Wnt isn't bound. So on the right, this is what it looks like when the Wnt is bound and disheveled can binds to the destruction complex, and they can't phosphorylate beta-catenin anymore. And so the beta-catenin can get into the nucleus of the cell, and it causes cell proliferation and differentiation. So some consequences of the APC mutation is that it has increased cell proliferation, which means beta-catenin is unable to degrade and will activate the LCF transcription factors, which drives the expression of genes that promote cell proliferation, and then the loss of control over intestinal stem cell division and chromosomal instability. These together begin the formation of colorectal adenomas, which can continue into a more serious carcinoma. And as we can see on the left, this is what it looks like when it's just the beginning of an adenocarcinoma forming. So what does cetuximab target? It targets the hallmark of sustained proliferative signaling through the proto-oncogene EGFR. EGFR is an epidermal growth factor receptor that is typically activated by ligands TGF-alpha and EGF, and they control cell proliferation, cell survival, and cell differentiation. So the molecular biology of EGFR signaling is that when EGFR binds its ligand, like as we can see on the right, when it binds, the EGFR dimerizes and tyrosine residues autophosphorylate and the downstream pathways activate, so like RAS, BRAF, MEK, and ERK. And then these pathways promote cell proliferation and anti-apoptotic signals. So when there's a mutation in EGFR, so in colorectal cancer, overexpression and hyperactivation of EGFR is common. Overexpression or hyperactivation of EGFR can drive tumor growth, and cetuximab is the targeted agent that we're going to focus on, and it's a monoclonal antibody that binds the EGFR to prevent ligand binding and can inhibit tumor cell proliferation, apoptosis resistance, and increased invasion and angiogenesis.
So the public health problem that is colorectal cancer, the current incidence in 2022, which was the latest available data according to the CDC, incidence was about 147,931 new cases reported, which means for every 100,000 people, 37 new cases were reported. The current mortality, this one was in 2023, which again, the latest available data according to the CDC, was 53,779 people who died, which means for every 100,000 people, 13 died of this cancer. So the places that the most cases were reported are Kentucky, West Virginia, and Mississippi, as you can see in the map below. Those ones are the darker blue. So the variations of this, the type of people who have it, the colorectal cancer is more common in men, but because they have a rate of 41.4 per 100,000 people, while women only have a rate of 32.5. Um, it's most common in American Indians and Alaska Natives with a 42.2 rate per 100,000 people. So I chose the observational study risk factors for the diagnosis of colorectal cancer. The main objective of this study was to identify and evaluate patient characteristics, demographic, and lifestyle factors that are associated with colorectal cancer at diagnosis. The background of the study, it was a case control study. It was observational and an analytical study with a control group. The study included 800 patients from the Potokopaki Clinical Oncology Center and Provincial Hospital in Reservoir in 2019 through 2020. The study had 400 patients that were diagnosed with colorectal cancer, and then 200 patients diagnosed with a different cancer. This was control group 1, and then 200 patients with a disease that wasn't cancer. That was control group 2, and they were assessed for their activity, BMI, and then there was also a lifestyle questionnaire given. So the results of this were the average person with colorectal cancer is typically older. So the older you get, the more likely you are to get it. There was a strong positive association between ulcerative colitis and the risk of colorectal cancer. Then obese people also had a risk factor of 1.27, meaning that these people had 27% higher risk for colorectal cancer. There was also a strong positive association between low activity and the risk of colorectal cancer. And smokers had a 2.17 risk factor, meaning they were 2 times more likely to get colorectal cancer. Yeah.
Okay, so the efficacy and side effect profile of our intervention. So I chose an intervention study that was from December 2003 to August 2005 that included 572 patients who had colorectal cancer expressing the detectable EGFR and who had been previously treated with other drugs and had issues with these drugs. So they randomly assigned 287 to the Cetuximab plus best supportive care group, and then 285 to just best supportive care alone. They gave the Cetuximab group an initial dose of 400 milligrams per square meter of body surface area, followed by a weekly infusion of 250 milligrams. So the primary endpoint was overall survival. The median overall survival for cetuximab group was 6.1 months, while in the supportive care alone group it was 4.6. The hazard ratio for death was 0.77, and the hazard ratio for disease progression or death was 0.68. The quality of life was better preserved in the cetuximab group, with there was less deterioration in physical function and global health status scores. So the analysis of the cetuximab drug, so the risk benefit analysis, so the main risk of cetuximab shown was a rash, and it was 11.8% in the cetuximab group versus 0.4% in the supportive care alone group. There was also risk of infection, which was 12.8% versus 5.5%, as well as confusion, which was 5.6% versus 2.2%. And then in the pain defined as other, there was 14.1% versus 7.3%. However, there was no statistically significant grade 3 or higher adverse events. So cost benefit analysis, cetuximab is expensive, but the high cost is often offset by improved survival rates. So in figure one, this shows the overall survival in the two groups. Overall, the total number of deaths was 456, and it was 220 in the cetuximab group and 234 in the supportive care group alone. So the addition of cetuximab to supportive care resulted in a longer overall survival than just the supportive care alone. So in all, cetuximab improves overall survival and progression-free survival, as well as preserving the quality of life measures in patients who have colorectal cancer and have not had any other success with any other treatment.
So the clinical subtypes include colon cancer and rectal cancer. And it's also important to note that there are tumors begin to form on the left or right side, and that is because the right side is often asymptomatic for longer, and the left side is shows signs more sooner because the tumors begin to grow inwards. Uh, go. So polyps are the first abnormal growth in the development of colorectal cancer, and these polyps form when the colon epithelial cells acquire mutations that normal growth control. These key early mutations include APC gene loss, KRAS activation, TP53 mutations, and the first stage is often asymptomatic, and it's a good prognosis in the early stages because the tumor is still often localized. Middle stages, the tumor growth grows beyond the mucosa and submucosa into deeper layers, and this tumor enlarges and can now lead to potential symptoms that disrupt colon movement. Local spread, it began entering nearby lymphatic channels, and these regional lymph nodes now have the possibility of containing cancer cells. An increase in genetic change throughout the middle stage, and this includes mutations that accumulate in signaling pathways such as the EGFR, KRAS, TP53, SMAD4, and the P13K. The tumor becomes more aggressive here and resistant to apoptosis, and the microenvironment changes include inflammation and growth of blood vessels. This is a moderate prognosis in the middle stages because tumor has now grown deeper into the cell wall and may have started to invade nearby tissues. Clinical findings in the middle stage, palpable mass may be felt during colonoscopies, lymph node involvement on imaging, and elevated CEA levels may begin showing up. There's often CT or MRIs, and then if you look into the left, it's a normal MRI scan, and the one to the right is clearly a thickened bowel wall, narrow lumen, or nearby lobe enlargement. Late stages, this is when the cancer has become metastatic and has spread to the liver and lungs. These symptoms now include severe abdominal pain, obstruction, jaundice, cough. They can cause liver dysfunction, fatigue, and a lot more. The tumor becomes highly aggressive and disease controlling. Average patient experience on intervention. Early stages, the patient's usually asymptomatic. As it goes on and develops, there's changes in bowel habits, bleeding, and weight loss. And then cetuximab can often cause skin rashes and fatigue. So the rationale and development of the targeted therapy, cetuximab binds to the EGFR receptor on cancer cells, and this works by preventing the EGFR from being activated, which shuts down downstream pathways and blocks tumor growth and can shrink tumors. It's very specific to the EGFR and does not affect cells with KRAS or NRAS mutations unless they are wild type. Cetuximab breakdown has a narrow therapeutic index. There's a small margin where the medication is considered safe and effective. And the main limitation of this is that it can block healthy skin cells in the EGFR and not necessarily tumors, causing severe rashes. It's also often used with chemotherapy such as FOLFOX and FOLFIRI to completely eliminate the tumors. Basic science knowledge that led to the development. Researchers discovered that the EGFR drives the colon cancer growth, and that blocking the EGFR slows or stops the tumor, and that the RAS mutation can keep the pathway active even if the EGFR is blocked. And this led to the cetuximab, which is an EGFR antibody drug, and also mandatory RAS testing before treatment. our citations. And thank you.